Welcome, everybody. We are going to be talking about asynchrony and how it relates to your patient mechanical ventilation. But first, got some quick housekeeping items. I am a current clinical application specialist for Hamilton Medical. So I do work for a ventilator company, even though everything I'm going to tell you tonight is going to be able to be utilized on any ventilation or any ventilator from any company. So we got a problem. Traveling the country, we tend to see a lot of different waveforms, and they're described actually fairly similarly across the country. I hear a lot of, oh, the waveforms are messy or the waveforms are ugly. And most therapists will know a little bit of what to do to rectify that. But when the doctor comes over, like, how'd you fix it? And they're like, well, it was messy and I made it look clean, or it was ugly and I made it look pretty. And it doesn't instill a lot of confidence in the doctor. So hopefully, this is going to teach you not only how to identify asynchronies and fix them, but also how to verbalize it and justify your decisions verbally using the actual technical terms for these asynchronies. So, little polling here. What asynchrony is present? Okay. I don't know if Keith is going to
Keith is 1 second.
All right. So let's talk about this a little bit. All right. Let's pull that down. Okay, so what do you see here? Is it flow starvation? Is it double trigger? Is it a delayed cycle? Is it a reverse trigger? Or I have no idea. And it's okay to have no idea. That's why you're here. This is continuing education. So it looks like a lot of people are saying flow starvation, flow starvation, flow starvation. Double trigger sneaking up there with about 18%. All right. So looking here, we have, hold on, let me pull it up here. So flow starvation won out, even though it is not the correct answer. Sorry to say. It's actually a double trigger. And we'll talk about why that is in a little bit. But flow trigger can be double trigger can be caused a little bit by flow starvation. Next. All right. Which synchrony is present? Actually, yep. Which synchrony is present? When I say synchrony and asynchrony, please know that they are interchangeable terms, right? So do we have a delayed cycle? Do we have an early cycle? Do we have flow starvation? Or trick question, there's actually no asynchrony here. And again, you can have nothing, you can have no idea. All right. So let's see what everybody puts in here. Early cycling, delayed cycle. Early cycling is getting the lion's share of it. All right. Looks like early cycling's winning out. And for those of you that chose that, that is correct. And we'll talk about why in a little bit. Next. This is the last one I'm going to give you guys. So what's going on here? Is it a patient-initiated breath? Is it a reverse trigger? Is it an auto trigger? Ventilator-initiated breath? Or again, you can have no idea. Fun fact: there are actually two correct answers here, and so just so you know, there are in fact two correct answers. But go ahead and tell me what you think you're looking at here in terms of asynchronies, right? patient-initiated breath, reverse trigger, auto trigger, ventilator-initiated breath, or you could have no idea. Let's see the poll popping up. Let's take another second to take a look at it. Oh, there it is. There it is. Auto trigger, auto trigger, auto trigger. Ventilator initiated breath. Nobody else is picking patient initiated breath. Oh, there it is. First trigger. All right, well, it's supposed to be an auto trigger, but yes, there are some patient initiated breaths in there. So if you chose that, you are also correct. If you're unfamiliar with Hamilton Medical's ventilators and their technology, I know every single ventilator company denotes spontaneous efforts differently. For Hamilton, it is either yellow triangles or pink triangles under the pressure waveform. That means that it was a patient-initiated breath. All right, and this was in fact an auto trigger. But again, we're going to talk about all these as we go along, and then we'll give you a little quiz at the end to see how well you did. Right. So first, we're going to talk about synchrony and worker breathing. Right. Can't really talk about synchrony and asynchrony unless we're all on the same page on what they are. So synchrony is defined as a simultaneous occurrence between two entities or a harmonious interaction between two entities. In this case, we're talking about the patient and the ventilator. And then asynchrony is the opposite of that. It's a concordant relationship between two entities, chaotic relationship, if you will, lack of synchronization. And I've got it depicted here using Dirty Dancing as a example here. They're doing the move, right? Look how awful they are in the asynchrony section, and then look how nice and well defined that move is on the synchrony one. Okay, so this is what synchrony and asynchrony are, right? And when you apply that to a ventilator, you know, as respiratory therapists, it's our job to figure out what the patient wants, right? Because every patient has a set neural respiratory pattern that they want to follow. And I don't know about y'all, but I'm not a mind reader. So the only way I can discern what the patient wants is using the ventilator waveforms. Now, if you look over here on the left, this is a synchronous patient. They're able to trigger the vent when they want a breath. They're able to cycle in an exhalation when they are finished with their breath. And they're giving the adequate amount of support. And if you notice, all of these waveforms are pretty uniform looking. They're pretty homogeneous. Whereas over on the asynchrony side, there's actually a whole bunch of asynchronies going on here. You got a miss trigger there, you got a double trigger there, you got another double trigger. So there's just a whole myriad of stuff going on here. And going around the country, I hear it described mostly as, oh, waveforms are ugly or waveforms are messy. But they can't really go farther down that rabbit hole on why they're messy or why they're ugly. So when we're talking about ventilation, we should always talk about independent and dependent variables. Okay, independent variables, those are what you set on the ventilator. Those are fixed, those do not change, right? Whereas dependent variables, they're not set, they're not fixed, and they will change over time with changes to your patient's pulmonary mechanics. Okay, now if we're looking at the three main modes of mechanical ventilation. Again, for those of you unfamiliar with Hamilton Medical, we call fixed flow volume control SCMV. And then you got pressure control, and then you have spontaneous or pressure support. Okay, so what do we set? What are the independent variables in volume control? What do we set? Well, we set volume, flow, and I time. So what's variable? What varies? Pressure. And then when you look at pressure control, what do we set here? Well, we set pressure and I time. right? So what varies here? Well, it's volume and flow. And then with spontaneous, what are their independent variables here? Well, there's just one, pressure. So what varies? What changes? Volume, flow, and I time, all of those. And ultimately, you want to go from a mode with less flexibility to a mode with more flexibility as your patient wakes up and starts to become more active, and starts to head towards extubation, right? So essentially, pretty much every mechanical ventilation course that you're going to see goes from a less flexible mode to a more flexible mode. Now, looking at the pressure and flow time waveforms, we have volume control over here, pressure control over here. You can tell because flow is fixed. It's the same on every single breath. It might vary a little bit on the pressure scale, right? Whereas pressure control, pressure is fixed. It's the same every breath. But airflow is wildly different from breath to breath, okay? So independent variables on volume control, it's flow and volume. And that's why you see your flow waveform being so uniform. This is how to tell these two apart. And the other thing we're going to talk about is lung protective ventilation, diaphragmatic protective ventilation. Now, everybody knows what lung protective ventilation is. It's the first thing you learn about when you learn about ventilation in school. And pretty much every patient you round on, lung protective ventilation is brought up at some point during their ventilatory course. But diaphragmatic protective ventilation, not many people have heard of that. It's a fairly new concept. And it's based on a lot of literature that's been coming out in probably the past 5 to 10 years. And essentially, with lung protective ventilation, you should only practice that on passive patients, patients who have no spontaneous effort, right? And you want to minimize your driving pressure, optimize your PEEP, right? Whereas with diaphragmatic protective ventilation, this should only be done on active patients, right? And you want to focus on figuring out what the patient wants and then giving it to them. There's no, oh, I want this patient to have 6 per kilo. If they want 8 per kilo, they're going to destroy their diaphragm getting it if you don't give it to them. So just give it to them. And what you want to do is ventilate them so that they're utilizing the least amount of energy to ventilate themselves with their diaphragm. Okay. And where this comes from, one of the main ones is this that was done by Gallagher, where they pretty much came up with this term called myotrauma. Essentially, what myotrauma is diaphragmatic failure. And what they found was with a very high synchrony index, patients would overwork their diaphragm, and then it would become non-functional, and they'd have to be trached and sent to rehab because of this. And it was not ever a patient problem where they came into the hospital with a damaged diaphragm. That was given to them at the hospital. So myotrauma is almost always an iatrogenic injury, right? It's given to them at the hospital. And it's done by setting them on ventilator settings that they're not comfortable with, and they fight the ventilator. Just think, if you set me at 400 cc's and I want 600, am I going to acquiesce to the ventilator when I don't get that 600 and say, okay, I'll let the ventilator, do whatever it wants? No, I'm going to struggle and try to get that 600 that I want. And the diaphragm's a muscle, and just like every other muscle, if you overwork it, it'll become useless for a time. So just imagine if I were to do 1,000 bicep curls right now, which I totally could. Well, what would happen? For a week after this, I wouldn't be able to move my arms. I'd have spaghetti arms, right? Same thing happens to your patient's diaphragm when they fight the ventilator for too long. Their diaphragm becomes totally useless, turns to jelly, and now you have to trach them and send them to rehab. And I'm pretty sure if you think back on your careers, you can find a patient or 2 or 3 who were intubated for something relatively benign, but you just couldn't seem to get them extubated. They wound up having to be trached and sent to rehab. That was probably because they fought the ventilator for too long and they destroyed their diaphragm doing it. So looking at the causal pathway that they lay out in this, right? So you have mechanical ventilation, right, which leads to diaphragm injury by way of abnormal inspiratory effort. And then the longer you have these injurious settings to your patient's diaphragm where they're working against the ventilator, you get diaphragmatic weakness, which leads to prolonged mechanical ventilation. And then either ventilator dependence, can't get them extubated, you got to trach them, or even death. There have been a couple studies that have come out in the past few years that link high asynchrony indexes to mortality. So over time, this has been known to contribute to mortality. Okay, so there's three types of asynchronies that we're going to look at today. There's trigger asynchronies, flow asynchronies, termination asynchronies. The first one is going to be the trigger asynchrony. And the first one we're going to talk about is the delayed trigger. So this is what happens when your patient makes an effort, right? They start taking their breath, and the ventilator does not recognize that effort and deliver the appropriate amount of support in a timely fashion. There's a delay, there's disconnect in that. So go ahead and ignore this chart for a second. We're going to come back to that. It's going to come very important in a little bit. But for now, just kind of ignore that. So the delayed trigger, if you look here, you'll see that pressure starts to dip pretty long time before the ventilator actually triggers the ventilator and starts delivering support, right? And if we go ahead and blow that up and measure it out, it's about 0.3 seconds, right? So this patient is struggling with no support for 0.3 seconds. Now, I know that doesn't sound like a long time. When you run out of breath, that's actually a really long time, right? So looking at the flow waveform, right, you'll notice that the patient doesn't start getting actual breath delivery until you hit this linear increase in flow right here, this nice straight line, this linear increase, this jagged increase in flow. That's all the patient making an effort with no ventilator support to help them out. But your big tell in every waveform is going to have a tell, something that when you walk in the room, it's going to pop right out to you. Sometimes it's in the pressure waveform. Sometimes it's in the flow waveform. Well, on this one, it's usually the pressure waveform. Because can you really notice that jagged increase in flow before the linear increase? No, it looks the same as every other breath. But you can definitely notice that prolonged dip in pressure before the breath. So that should always be your tell. Now, we've included the esophageal waveform here. And if you're unfamiliar with esophageal manometry, it's a whole nother hour-long lecture. But for the purposes of this lecture, all you need to know is that esophageal manometry measures pleural pressure, right? So these dips that you see in the pleural pressure are patient effort. It's a diaphragm contracting, creating negative pressure in the thorax. So if you notice, the patient's effort starts where this line is, but the ventilator doesn't actually start delivering support until way over here, right? So what causes this? All right. Easiest one. Your ventilator sensitivity is set too high. Your ventilator is just not sensitive enough to recognize patient effort. You can have ventilator pneumatics, anything causing auto peep. So clogged up expiratory filter, waterlogged expiratory filter, any kind of kinks in your tubing or anything like that. The presence of auto peep will cause this. And I know a lot of times when people think, oh, how does auto peep cause an inability to trigger the ventilator? Well, or inability or a delay in triggering the ventilator. Well, that's because when a patient triggers the ventilator and they have auto peep, they have to breathe through the auto peep and then through whatever threshold for triggering you have set to trigger a breath. So say, I know not a lot of people use pressure trigger. but for easy math, easy way of explaining it, let's just say our patient's on a pressure trigger of -1, and they have -4, or they have 4 of auto PEEP on board, which means the patient has to breathe through that 4 of auto PEEP and then another centimeter water pressure to trigger the vent. So instead of the 1 centimeter water pressure that you have set, that you think they have to generate to trigger the ventilator, they actually have to trigger 5 centimeters of water pressure. They have to pull in and create a negative pressure of 5 instead of that 1 that you think, right? So this could create a delay in triggering or even a mistrigger, which we're going to talk about in a little bit. Weak respiratory drive, obviously. Poor effort, that goes in the same bucket. And then the last one, too much inspiratory support. So this is where this chart comes in. So this comes from a study that was done in 1997 by, I love this, life can't get better than this, Dr. Lung. Dr. Lung is writing papers on mechanical ventilation. How fantastic is that? Anyway, what he found was that as inspiratory support increases, respiratory drive decreases and diaphragmatic strength decreases, right? So you may have too much support set. Your pressure support could be too high. Or if you're in a control mode, you're giving too much volume, you're giving too much pressure, right? Basically, it is too much support, right? So how should we fix a delayed trigger? Well, easiest one is turn your trigger down, make it more sensitive, right? Second one, check your environment, remove any obstructions in the ventilator tubing, restrictions, change out your filter if it's got water in it, basic stuff like that, and then reduce auto PEEP. So how do we reduce auto PEEP? And this is another thing where I go to a lot of hospitals and I'll say, oh, they got auto PEEP, should probably go up on your PEEP. And the doctor will be like, whoa, 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 no, they're already air trapping. I don't want to give them more PEEP. And what they don't understand is that for obstructed patients, right, and patients with auto PEEP, going up on your PEEP actually stints open those restricted airways and allows air to move freely back and forth. So actually going up on your PEEP is going to help with auto PEEP, right? Because it's going to make air be able to move in and out of your lungs much, much more easier, right? Because you'll have a bigger lumen to do that. And then going back to Dr. Lung, we can reduce our level of inspiratory support. Next, we have an ineffective effort. The causes and fixes are going to be very similar to the delayed trigger. But essentially what happens here is the patient makes an effort and the ventilator just doesn't recognize it at all. Right? So if you look here, we have the electrical activity of the diaphragm, we got a pressure waveform, and then on the top we have our flow waveform. You see our patients make an effort here, the electrical activity in the diaphragm is popping off, but the ventilator is not sensing that and delivering the appropriate amount of support. So in flow, you have this little bump in flow. Pressure, you have a little dip in pressure. But your tell is going to be the flow. I'm telling you. So you have your little dip in pressure right there. Can you really tell that dip from all the other artifact that's going on in this waveform? No, not really. But can you see this bump and flow? Yeah, it just pops right out to you, right? So this will be your tell that your patient is missing triggers, is that bump and flow, right? And we're going to blow this up and just show you increase in flow, but no ventilator delivered support, right? During the expiratory phase. This is most definitely a missed trigger, right? That little bump and flow is gonna tell you right there. And now we've included the pleural pressure. So if you notice, there's an effort here, there's an effort here. Every dip is an effort. Now, our missed trigger, less of an effort, right? Less of a dip, which means the patient did not make an effort as strong as the other efforts that are depicted on this waveform. It's probably why the ventilator missed the trigger, but nonetheless, it was an effort. So what caused this? This is going to look exactly the same as a delayed trigger, right? Your trigger threshold is set too high. It's not sensitive enough, right? Pressure support is too high. Goes back to Dr. Lung's study. And then again, with the too much support, the frequency or eye time is too high, tidal volume too high. That all goes into that too much support bucket that Dr. Lung did. And then down here you have presence of auto PEEP, right? We talked about that. And low respiratory drive, weak inspiratory effort, sedation, those all go into the same bucket as well, right? So how should we fix a mistrigger? Well, this is going to look very much like a delayed trigger. So easiest thing, turn your trigger down, make it more sensitive, right? You could reduce the level of support your patient's on. You could increase your PEEP to counteract that auto PEEP if it's present. You can also check your ventilator tubing for any thing causing auto PEEP. And then also talk to your medical team. See if you can't reduce the level of sedation they're on, or try other things to increase diaphragmatic strength, right? Now we have my favorite, and it's also the most recognizable, is the double trigger. Now, I've heard so many different names for this asynchrony. You got the cowboy hat, you know, it looks like a 10-gallon cowboy hat, bunny ears, the camel humps, the double clutch. But whatever you want to call it, it is a double trigger. Okay. And what this is this is a mismatch of the set machine eye time and your patient's neural eye time. Okay. It could also be attributed to a lack of support as well. But essentially, how it's defined is two or more breaths that are delivered subsequently with little to no exhalation in between them. That's the kicker. The patient is not exhaling in between these two breaths. So, looking at it on an actual ventilator waveform, and this is pretty much the only time you can pick it out any synchrony on a volume waveform, but you can pick it out on anything. You don't have a specific tell here. You can see it on the pressure, you can see it on the flow, you can see it on volume. And what you'll notice is your patient is not exhaling. So say you're working in the ICU, you got a patient with ARDS. You know, you got them on 6 per kilo tidal volume. They keeping that plateau under 30, right? You got the PEEP optimized. You're like, man, I'm crushing this ARDS-net ventilation. Well, then they start double triggering. What happens then? Are they still getting 6 per kilo? No, they're not. They're getting 10 or 12 per kilo, right? Because they're getting 2 breaths stacked together and they're not exhaling in between them. So your lung protective ventilation has just gone right out the window. Okay. So looking at it here, I haven't unveiled the bottom part, but essentially, your patient, the reason why the double trigger happens is because the ventilator cycles into exhalation in the middle of the patient's inspiratory effort. Right? That's why you get that immediate second triggers, because the patient is still making effort when the ventilator cycles into exhalation. So in actuality, this patient's eye time should encompass both of these breaths. Right? And if we bring it up with pleural pressure, we'll see that their effort starts right here. They're able to trigger the ventilator fine, right? There's no delayed trigger, there's no mistrigger. They're able to trigger, but then the ventilator cycles into exhalation while they're almost at the peak of their effort. And that's why you get that immediate second trigger. So, causes in pressure support ventilation, it's your cycling criteria. Now, every ventilator company calls this something different. Hamilton Medical calls it expiratory trigger sensitivity, or ETS. PB calls it E-sense percentage. Servo calls it flow term percentage. Vieira calls it flow cycle percentage. Either way, with the double trigger, that means that it is set too high. And how this works, if you're unfamiliar with this particular setting, is it is a way to titrate your patient's eye time in a pressure support mode. Now, I know in RT school, they're like, oh, pressure support, patients assess their own eye time. That's not totally true. We have a little bit of a say, and it is your cycling criteria. So the higher the number, the shorter your patient's spontaneous eye time. The lower the number, the longer your patient's spontaneous eye time. If you're in a control mode, it's very simple. Eye time's too short, right? Or you could be giving insufficient support. Say your patient wants 600 cc's, you got them set for 450. They're gonna keep trying to get that extra 150 after it cycles into exhalation, right? Yep, sure are. So, how do we fix it? Well, number one, you turn your cycling criteria down. Okay, in a control mode, it's very easy. You lengthen your eye time. And then in both modes, you can also try increasing support. I generally go with the first two options when I'm at the bedside because you don't have to have a conversation with the doctor or the rest of the medical team. You can just do it usually. Although increasing support, you're going to have a conversation. So I usually go with the first two first, see if I can fix it that way. All right, auto trigger. So auto trigger is essentially what happens when the patient does not make any effort, but the ventilator triggers a spontaneous breath. Okay. Now, if you look here, we've got this little baby breath here, right? Both spike in pressure and flow. But looking at our diaphragmatic electrical activity, nothing is going on there, right? Same thing with over here. Got this spike in pressure and flow, no diaphragmatic activity. And then same right here, right in the middle, no diaphragmatic activity. You've got these spikes in pressure and flow. Now, the tell is going to be in your pressure waveform, and it's not always going to be super visible. But after seeing this, you should be able to look for it at least. So a normal inspiratory effort on a normal patient, at the beginning of inspiration, you're going to see a dip in pressure, a small dip in pressure, not a prolonged one like a delayed trigger, but a small dip in pressure, right? Because the diaphragm is contracting, it's creating negative pressure here. So you should see a little dip in pressure before the ventilator starts delivering its breath. Now, if you don't see that dip in pressure, it's probably an auto trigger, okay? All right, so looking at this auto trigger, you can see we've got it right there. And if you look here, not really a dip in pressure, whereas you got a pretty good dip in pressure there, right? Decent dip in pressure there. And then let's bring up our pleural pressure. So as you can see right here, patient's not making any effort, but yet there is a spontaneous breath being delivered by the ventilator. So how do we fix it? Well, this time your trigger's probably too sensitive. So you should turn it up, make it less sensitive. If there's any leaks in your circuit, chest tubes, a giant air leak, stuff like that, that could cause this. And then our good old friend oscillations in the tubing. That could be from secretions and rainouts sloshing around in your circuit. Could be a hyperdynamic pericardium if you're in a cardiac unit, where the heart will actually cause auto trigger. It will actually trigger the ventilator because it's beating so hard. So how do we fix the auto trigger? Probably the first what you should do is check your environment, clear any, anything sloshing around in your circuit, check for leaks, and try to resolve them if you can. Adjust the sensitivity, okay? Make it less sensitive, turn it up. And then for cardiac oscillations, what we have found is that what I see people just jack up the flow trigger to something ridiculous like 12 liters or 15 liters or something, right? To lock the heart out. But when you do that, you also lock the patient out. The patient couldn't trigger either. But what we found is if you just switch to a pressure trigger, it doesn't even have to be an aggressive pressure trigger, like pressure trigger -1 or -2. It'll lock out the heart, but still allow the patient to be able to trigger the ventilator spontaneous if they want to take a breath. So for cardiac oscillations, for a hyperdynamic pericardium, just put them on a pressure trigger, just normal pressure trigger, -1, -2, and it'll lock that heart right out. All right, reverse trigger. This is a bit of my baby. I've got a whole another hour-long lecture just on this, but I'm just going to spend a minute or two on it here. So, reverse trigger is a very rare phenomenon. Well, not very rare, but you won't see it that often. Maybe every 3 to 6 months if you work in a surgical unit. And it's a phenomenon that happens with deep sedation. For some reason, opioids tend to be the biggest culprit. But what happens is the ventilator will deliver a passive breath, right? Patient's not triggering at all. And that breath will stimulate the diaphragm to take a breath in the middle of the vent delivered breath. Okay. Now, where this comes from, it's a reversal of the Herring-Brewer reflex and the stretch receptors in the lungs. Normally, when the lungs fill, the stretch receptors activate and they tell the diaphragm to stop contracting and start relaxing because it's time to exhale. We're at maximum capacity, right? Well, in cases with deep sedation, that reverses. So when the stretch receptors get activated, it actually triggers the diaphragm to contract and take an even bigger breath. Now, reverse trigger is very, very commonly mixed up with a double trigger. They look almost identical. If you look here, looks like a double trigger, right? But if you look at when the patient starts their effort, that's after the ventilator has started delivering a passive breath, because you can see first breath in this, there's no pink triangle. It means the patient did not initiate it, the ventilator did. And then patient ends their effort right there, okay, before the ventilator cycles into exhalation. Now, this isn't always the case with reverse triggering. Sometimes the patient will start making their effort in the middle or the end of the ventilator delivered breath. And this becomes a problem because both you and the ventilator think the patient's exhaling when actually they're still making effort during the time they're supposed to be exhaling. And by the time that diaphragm relaxes, the ventilator is going to give another breath and you're going to have air trapping, right? So looking here, how do we tell if this is a double trigger or a reverse trigger if we don't have an esophageal balloon in? And that's very easy. So a double trigger, you're going to have the patient is going to initiate both breaths in that double trigger, right? They're going to initiate both breaths. Here, only the second breath is patient initiated. That's one way to clue you in. The second way is if your patient's actually spontaneously breathing and you do an inspiratory hold, when it plateaus out, you're going to see them making many efforts, right, on the plateau pressure. With a reverse trigger, if you do an inspiratory hold, if you look over here on the right side of this waveform, the patient just makes one effort, and then that's it. So these two things should clue you in as a reverse trigger, okay? And like I said, you're not going to see it that often, maybe a couple times a year. It's fairly rare, but it is important to be able to pick out because if you think it's double trigger and you start going up on support and or rate, you could actually do a lot more harm because your patient's air trap. You're gonna worsen their air trapping. Looking right here, again, not a spontaneous breath, right? There's no pink triangle, so this is a ventilator initiated breath, right? And how do we fix it? Well, you can take the easy way out and do a neuromuscular blockade, paralyze them. But if you unparalyze them, probably going to have the same problems. Okay. So how can we fix this with the ventilator? Number one, you can increase PEEP. And I'm going to talk about why in just a second. You can also increase support, right? Tidal volume, pressure control, eye time. Frequency increases, I would steer away from. I know on the slide it says it should be taken with serious considerations for breath stacking, but I would just kind of avoid it altogether. And that's what I do because you just, without a balloon, you don't know which part of the ventilator delivered breath the patient is starting their effort and where they're ending it. So, but why increase PEEP? All right, so there's 3 studies that have come out in the past 2 years. So this is very new information. They're all done on, by the way, this is the best name ever for any type of injury. Silly, self-induced lung injury. And basically what they looked at was patients who actually give themselves lung injury with their work of breathing. And what every one of these found, so this was by Yoshida, this one's by Guillaume Carteau, and this one's by Neitz. I could not find one that's in English. I had to call up my Hamilton colleague in Germany and have him had him read it to me. But they all say the same thing. So what they have all found is that diaphragmatic contractility, the strength where the diaphragm contracts, is directly linked. It's almost a reflexive or instinctive thing to your patient's optimal PEEP and how close you are to that. So the farther away from the patient's optimal PEEP you are, the harder that diaphragm is going to instinctively and reflexively contract. So your work of breathing is going to go up if your patient is under PEEPed, right? The more under PEEP they are, the more they're going to work. And I want you to think outside of reverse triggering, but everybody's had those patients, where they're heaving and hoeing, chugging, and you're going up on the pressure support, you're going up on the pressure control, you're going up on the tidal volume, but you just can't capture them. Well, it's probably because they needed more PEEP. That's why they had such horrific work of breathing, is because they were actually too far away from their optimal FRC or their optimal PEEP. So next time you see one of those patients and you got your colleague like, God, I just can't capture this guy. I keep going up on the pressure support. He's still just sucking pond water. Well, go up on the PEEP, see if that works. Next, we have flow asynchrony. There's only one waveform in this, right? And this is probably the most harmful to your patient's diaphragm out of all the asynchronies I'm going to show you. This is going to be the one that will absolutely destroy their diaphragm the quickest. And the biggest culprit is fixed flow volume ventilation. So your typical volume control, assist control. Because what happens, you set flow and you set volume. What happens if the patient wants more flow? They don't get it. What happens if they want more volume? Yeah, they don't get that either, right? So what you get is this guy. So looking here, and I hear this described as scooping out, and I think it's a great description of it, so I'm going to keep it. So you've got this scooped out pressure waveform, and what this is showing is that your patient is not only stripping all the flow and volume out of the ventilator, they're also stripping all the pressure out of the ventilator, right? They're stripping everything the ventilator has to give them, and they still want more, right? Looking at it here, same thing. So what you want is a nice linear increase in pressure, but what you're getting is this scooped out pressure waveform, right? Or an upward concavity, right? Now looking at this one, so let's talk about just the basic definition of ventilatory support, right? So you could say that ventilatory support is defined as any amount of pressure above PEEP that the ventilator delivers would be considered support, right? Look at the middle of his breath. Is this patient getting any support? No, the pressure is at PEEP. They're not getting any support from the ventilator there. And you can tell because they are stripping everything that ventilator has to offer. All right, so what causes this? I know it looks like a lot of stuff right in here, but it's really not. There is one thing that causes this and one thing alone: not enough support, right? Either too little flow, too little volume, or a combination of the two, right? So the first one, probably inappropriate selection of ventilation mode. So if they're on fixed flow, first thing I would do is put them on something with variable flow. Literally every other mode on the ventilator has variable flow other than fixed flow volume control, or VCAC or SCMV if you use a Hamilton. High inspiratory effort, again, if they're under PEEPed, that is also going to cause this. Going back to the the stuff we just talked about with Yoshida and Carteau and Neitz, right? If they're underpeeped, they will have that instinctive diaphragmatic contractility that's going to cause lung injury. And this is going to be it. In volume control modes, not enough flow, not enough volume, or the I time is too long, which goes into the not enough flow category because those two are linked. In pressure control, again, not enough pressure control, I time is too short, and you could also have inappropriate rise time settings. Again, everybody calls it something different: ramp, slope, P ramp, slope, rise. It all does the same thing. But if that's turned way up and the patient's not getting to peak flow fast enough, then you'll see that as well. So how do we fix it? All right. Put them on a mode with variable flow or increase the amount of support that they're on. All right. Termination asynchronies. Early cycling. So this is what happens when the ventilator cycles into exhalation, but the patient's still making their effort. Now, I call this a gateway waveform because it can lead to our good friend, the double trigger. But usually you get this because the patient's kind of at the tail end of their effort, so they don't actually trigger a whole nother breath. But it's still important to be able to recognize because eventually the patient will try harder and harder to get the breath they want, and it will lead to a double trigger. So if you look at their diaphragm electrical activity, you'll see that the ventilator is cycling into exhalation while the patient is kind of at the back end of their effort, but they're definitely still making effort. And that's essentially where it's cycling into exhalation. And patient just needs more I time, right? How to pick it out on a ventilator waveform? You can have this little bump in pressure, but it's the bump and flow that is going to be your tell. You should be able to pick that bump and flow at the beginning of exhalation out as soon as you walk in the room, right? It's such a unique type of waveform, and I'm sure everybody's seen it. Say, hey, what is that little bump and flow at the beginning of exhalation? That's your patient still taking an effort. That's why you're getting that bump and flows because they're still making effort while the ventilator is cycled into exhalation. And if you're looking at your esophageal waveform, so patients definitely able to trigger when they want the breath, right? There's no problem with triggering here. But the ventilator cycling and exhalation, when they're pretty much at the end of diaphragmatic relaxation or diaphragmatic contractility, and they're starting to relax their diaphragm, that's why you get that little bump and flows. The patient's not quite done yet. So you should actually be ending the I time about right there, right? So looking here, we've got some double triggers and some early cycling. So early cycle there, double trigger, early cycle, double trigger over here. So as you can see, it will lead to it, and you can see both of these in the same waveform like you are now. They kind of go hand in hand. And just blowing up that flow waveform, this bump at the beginning of exhalation is going to clue you in that your patient's still making effort. They need a longer I time. So what causes this? It's going to look just like double trigger, right? It could be not enough support, or your cycling criteria is too high. You turn it down. In time cycled ventilation, either not enough support or your I time is too short. You need to lengthen it out. And that's exactly what the resolution slide is going to show you, right? You're going to turn down your cycling criteria, increase ventilator support, and then in control modes, you're going to increase your I time and maybe increase your inspiratory support. Now we have the delayed cycle. So delayed cycle is when the patient is done their effort. They're ready to start exhaling, but the ventilator is still delivering support. As you can see, so we have the diaphragmatic electrical activity ends about right there where it starts to plateau out. And when you see these plateaus at the end of inspiration like this, that should clue you in that your I time is a little too long. Your patient is really done their effort. But This you'll see rarely. This you'll see very rarely, actually. Most of the waveforms that you're going to see, and I'll show you that in a little bit, but we're going to blow this up, right? So what your patient, how to figure out how much eye time your patient needs. You draw a line over the inspiratory curve where they're actually making effort, and then you draw a line over the plateau, and where they intersect is where you should be cutting off your inspiration, or yeah, you're cycling into exhalation. You can also do it with the flow, right, across the patient initiated portion, and then down where the ventilator actually starts to cycle. And if you'll notice, you draw a line through them, they'll intersect at the exact same point on both waveforms, right? So this patient actually needs this for an eye time, not the rest of that. All right, so looking at your flow waveform, what you're going to have is a sharp decrease. So this is actually your patient trying to exhale. That's why you're getting the sharp decrease in flow before you have a nice exponential or slower decrease in flow when the ventilator actually cycles into exhalation. Now, this is the guy you're going to see most often. I'm sure everybody's seen this. The pressure waveforms with the spikes at the end of them. What these spikes are at the end of your pressure waveform is your patient's trying to exhale and the ventilator's not letting them. Right? So, all right. Sorry. So blowing it up here, these spikes here is going to clue you in. This is your tell. It's going to tell you that this patient is trying to exhale, and the ventilator is just not letting them, right? So they need a shorter eye time. You can also look at the flow. You got this sharp decrease followed by more exponential decrease, but can you really pick that out off of any other flow waveform? Not really. Can you pick this out? Yeah, man, you can pick this out from outside of the room. All right, so what caused this? Essentially, your eye time is too long. So in pressure support ventilation, you need to increase your cycling criteria now, make your eye time shorter. You could also decrease the amount of support that your patient's on. Maybe they don't want all that support. That's why they're trying to exhale early. In pressure control, eye time's too long. Again, they could also be getting too much support. Volume control, inspiratory time is too long, right? Which means that your peak flow is set too low. Those two kind of go in the same bucket. And of course, too much support again. So fixing it, we're going to increase our cycling criteria, reduce our level of support, and also quite possibly reduce your rise time. Pressure control, shorten your eye time. Volume control, shorten your eye time. Increase your flow. Those two kind of go hand in hand. And take down your tidal volume if need be. I generally mess around with the eye time and cycling criteria first. And then if I need to mess with support, then I'll do that. So let's see what you learned. I'm just going to throw up the same waveforms, see if you can pick them out now. So what's this guy? Is this flow starvation, delayed cycle, double trigger, reverse trigger, or you can still have no idea? I might be a little hard on you though, because I just spent an hour talking about it. All right. Double trigger, double trigger. I love it. I love it. 86%, 90%, double trigger. I love it. You guys are fantastic. I love it. Next slide. If I can, there we go. All right, so what's going on here? I was even super nice to you. I gave you the pleural pressure to let you see what the patient's actually doing while the waveform is going on. So is this an early cycle? Is this a delayed cycle? Or is it a normal waveform? Maybe there's nothing wrong with this. Or you don't know. Take a pass, right? All right, so we've got trick question, normal waveform, delayed cycle. And I don't know, can I pass? Delayed cycles winning out though. Delayed cycles winning out. All right. Okay, so you were right. This is delayed cycle. And you can tell by this plateau at the end of inspiration. This patient's just ready to exhale. They're all done their effort. That's why you get this plateauing of the pressure. All right. Last one. What's going on here? And again, I gave you pleural pressure. You can see what's going on. So what do we have? We have a patient breath, machine breath, reverse trigger, auto trigger. Still don't know. I'm just done with this lecture. You can be. We are almost done. We got like one more slide, maybe two. All right. Patient breath. There's actually two right answers. So most of you are saying auto trigger. Some of you are saying reverse trigger. Now remember, it looks like a double trigger, but this was patient initiated, right? Which means that, remember, the first breath in a double trigger, if it's ventilator initiated, if it's not spontaneous, it is a reverse trigger. This would actually be a auto trigger. There's no patient effort going on, but the ventilator is delivering a spontaneous breath. So that would be a auto trigger. All right. So can we have multiple asynchronies in one thing? Yeah. You got one, you got two, you got three, got a double trigger, miss trigger, another double trigger. So summary, it's important to do this because you need to practice diaphragmatic protective ventilation, right? When your patient wakes up and starts spontaneously breathing, it's your job to figure out what they want and just give it to them. Otherwise, they will destroy their diaphragm trying to get what they want, right? And we're not in the business of harming people. We're in the business of helping people. And if we destroy the diaphragm and have to trach them and send them to rehab, that's doing a fair amount of harm, okay? Asynchronies are usually the result of ventilator and patient neural eye time mismatching, right? They're just not in sync. And the waveforms will always help you figure out what's going on and how to fix it if you know how to read them right. Ineffective effort and double trigger, definitely the most common ones. Definitely double trigger. Everybody sees that all the time. All right. Thank you for your attention. And I appreciate it. Thanks for tuning in, guys. I hope everybody got something out of it, and I hope everybody had a good time.